Hey, what's up everyone? Welcome to Asylums Uncovered, where we discuss the influence and impact of state hospitals on American history and the void left in their absence. Today we're diving into a very specific treatment once used in state hospitals known as electroconvulsive therapy. You may know it better as electroshock therapy or ECT, and for purposes of this episode, I will mainly refer to it as ECT. And why am I covering this topic, you ask? Well, like many of you, I recently watched the Monster Ed Gein series on Netflix. And there's a scene that portrays Anthony Perkins, the original actor who played Norman Bates in Psycho, receiving electroshock therapy. And while it's reported that Perkins did receive ECT in real life, how realistic was the portrayal of this procedure? I realize this series takes plenty of creative liberties and includes its fair share of embellishments, but it got me thinking on a larger scale how pop culture often misrepresents asylums, mental illness, and psychiatric treatments, either by sensationalizing them or just getting the facts completely wrong. And you might be thinking, well, it's Hollywood, it's just a TV show, why does it matter? But the truth is, it does matter. ECT was a real procedure performed on real people, and it's important to separate the myths from the facts. Common misconceptions are that it damages the brain or it changes your personality. So let's dig into what electroshock therapy actually was and what it wasn't. How many of you have watched a movie or a TV show where a patient is lying on a hospital bed, electrodes strapped to their temples, a mouthguard placed between their teeth to prevent them from biting their tongue, and then a switch is flipped and their body convulses violently as the electric current runs through them? We've all seen that scene, right? It's in One Flew Over the Cuckoo's Nest, Girl Interrupted, American Horror Story Asylum, and the list goes on. According to an article on the National Institutes of Health website, electroconvulsive therapy, or ECT, has been depicted in 52 films and 21 television shows. Now, that data is from 2016, so the number is likely even higher today. The article also notes that in most portrayals, ECT is shown as a form of punishment, behavioral control, or outright torture. And that kind of imagery creates a massive misunderstanding and stigma of what this procedure initially was meant to be. It was created to help people, and like most psychiatric treatments, has been refined and improved throughout the years. In fact, it's still a procedure that is utilized today with impressively high success rates. The origins can be traced back to the early 1930s. It really began with Hungarian neuropathologist Ladislas Meduna, who was one of the first to treat mental illness by intentionally triggering seizures with a drug called metrazol. Also at this time, Austrian psychiatrist Manfred Sakel was experimenting with insulin coma therapy, which you'll often see referenced alongside metrazol convulsion therapy and ECT, but for this episode, I'm only focusing on the latter two. And I do want to warn you, some of this information is very dry, very clinical, and can be really difficult to follow, so I'm going to do my best to keep this as simple and digestible as I can. Meduna studied under neuropathologist and neurologist Carl Schaefer at the Inter-Academic Institute for Brain Research in Budapest. And while working there, Meduna observed different brain anatomy between epileptic and schizophrenic patients post-autopsy, particularly the presence of glia cells. Glia cells are described as the glue of the nervous system and are crucial in supporting normal brain function, regulating metabolism, helping neurons communicate properly, and cleaning up any debris that may hinder your nervous system from functioning properly. Through his observations, Meduna concluded that epileptic patients had an abundance of glia cells, whereas schizophrenic patients had an absence. This was an important discovery that supported the already widely accepted belief that epilepsy was not common in schizophrenic patients. So that got Meduna thinking, there's something here with these seizures. There has to be a reason why we don't see epilepsy in schizophrenic patients. Now, here's the tricky part for Meduna. His boss, Carl Schaefer, did not believe that schizophrenia could be cured, so Meduna did a lot of his research in secret. He believed the answer was within seizures or convulsions. Meduna's first patient was a man in his 30s diagnosed with catatonic schizophrenia, and catatonia is when a patient is unaware of the world around them, having little to no reaction of their surroundings. They're often unresponsive, very frozen or rigid, do not speak or feed themselves, and can't function independently. The initial thinking was that artificially induced seizures would help alleviate those symptoms. And although no one truly knows how it works, scientists do know that seizures can reset brain function much like rebooting your computer. So that was the main thinking in inducing these seizures. After several intravenous camphor treatments over the following weeks, Meduna reported that the patient had recovered, becoming able to walk, talk, and feed himself. And this was seen as a major success. Imagine a patient being so unresponsive they had to be fed with a feeding tube to suddenly walking around, talking, functioning totally normal. If you'll notice, I said camphor there, not metrazole. When Meduna first started doing his procedures, he used camphor, a chemical you might recognize today in things like Vicks Vapor Rub, giving it that cooling sensation. Over the next 10 or so patients, Meduna was seeing positive results and took his findings to Schaefer, who basically shunned him, asked who he thought he was, thinking he could cure schizophrenia, and forbid him from publishing his findings. Schaefer was very unhappy. He was having absolutely none of it, and he also said he denied that Meduna ever studied under him if anyone asked. So remember, Schaefer didn't think that schizophrenia could be cured. So here comes his student saying not only can it be cured, but he has the remedy. Meduna pretty much told his boss to pound sand and published his findings anyway in 1935. Switching back and forth between camphor and metrazole, he ultimately preferred the latter, stating it was more soluble and quicker acting. If you're unfamiliar with metrazole, it's a stimulant that was once used to boost breathing and circulation, usually when someone was in a coma or had a very low pulse. Basically, it would kickstart the body, but however, in higher doses, it can cause sudden, violent convulsions. Because of its unpredictability and high risk, patients could experience uncontrollable seizures and even have injuries like broken bones. Dosage was a bit of a guessing game, as physicians weren't exactly sure how much metrazole it would take to produce a seizure. So the patient was just laying there waiting, riddled with anxiety. Metrazole was soon abandoned and replaced with a safer and more controllable method, using electrical currents to induce a seizure. A side note, metrazole is no longer used in medicine today and has been banned in the United States since the 1980s. And I do have to give Meduna credit because from what I could gather, he always remained humble, claiming that his findings were the best option until something better came along. Building on Meduna's research, in the late 1930s, Italian neurologist Ugo Cerletti and psychiatrist Lucio Bini took the concept of seizure-based therapy a step further. After noticing that patients with epilepsy often experienced mood improvements following seizures, they began experimenting with electrically induced convulsions to treat disorders such as depression and schizophrenia. Cerletti is known as the father of ECT. And at first, this new procedure was used to treat many different disorders, as doctors lacked the data to identify which patients were most likely to benefit. In Italy, April 1938, police bring a man in his 40s to Cerletti's psychiatric clinic after he was caught trying to board the train without a ticket. The man was a mechanic from Milan named Enrico, and by all accounts he seemed lucid, he knew where he was, but he was talking nonsense about his thoughts being transmitted to others. Cerletti diagnosed him with schizophrenia and determined he would be a great candidate for ECT. He received the treatment over several weeks and was considered the first successful case after his delusions disappeared. And what may surprise you is that the first time ECT was administered to Enrico, it did not work at all. Cerletti and his team administered volts of electricity 3 separate times, and none of which induced a seizure. A little over a week later, they tried again. But this time, they increased the voltage from 80 to 92, which seemed to produce the desired outcome. Enrico convulsed, went unconscious, and then had short-term amnesia directly after, recalling no recollection of the event whatsoever. And after the procedure, he got up and simply walked back to his ward. In June, Enrico was discharged from the clinic, and Cerletti claimed that he was no longer suffering from delusions. However, the official records between Cerletti and his team told different tales of the recovery, but publicly, they claimed it to be a success. 2 years later, Enrico's wife wrote to Bini stating that her husband had been admitted to the Mombello Asylum in Milan and asked him to reach out to Cerletti for help. Bini did and noted that this was extremely urgent, but Cerletti didn't even acknowledge or respond, which in my opinion is pretty messed up. You used Enrico to push your narrative and say that ECT is a major success, and then you just discard him when he needed help. After this quote-unquote successful procedure, the word spread quickly. Headlines read, "Madness cured with electricity," and the duo was accomplishing quite a lot. Beeney obtained a patent for his ECT machine, and the new device was produced. By 1940, Serletti concluded the procedure was more beneficial for depression than schizophrenia and determined the appropriate voltage and duration of the current. Also around this time, ECT was becoming popular all over the world, including the United States. But what exactly was this procedure? In reading through historical reports, there's pretty detailed information about it, and of course, over the years, the process was refined and improved, so I'm going to try to generalize it and package it up nicely for you. Potential patients underwent an initial exam to make sure they were overall healthy before ECT was performed. This usually consisted of an X-ray of the chest and spine, an EKG to detect any heart abnormalities, and blood pressure, to name a few. The process was tweaked for each patient depending on their age, sex, or psychosis. Doctors would adjust how ECT was administered, the strength and amount of the current, and even how often they would receive it. Interestingly, females in their 50s or 60s had the highest tolerance overall to the procedure. Before treatment, patients would avoid eating a heavy meal, they would empty their bowels, remove anything from their mouth such as chewing gum or dentures, and change into a nightgown or loose-fitting clothes. Generally, the patient was either brought to the procedure area and laid on a table or remained in their own bed. Who was administering the ECT dictated what position the patient would lay in. For example, sometimes they would be on their back and sometimes they would be on their side. Overall, they were placed in a comfortable position that would allow for flexibility during the convulsions and limit any injuries. Nurses or attendants would help hold down their shoulders, but never tightly restrain them. An interesting fact from a 1950s report was that legs were never supposed to be restrained due to the injuries that could be caused. And this is something you'll see in movies or TV shows, or the attendants are holding down the patient's limbs tightly, forcing them to not move. In reality, that was most likely never the case, or at least it shouldn't have been. Their temples were usually wiped with an alcohol or a jelly for better conduction, and electrodes were placed on their head by a method of different contraptions, depending on the date administered. Sometimes they were on the end of forceps, sometimes a head clamp was used, and sometimes the small round metal discs were applied directly by hand to the temples. A rubber guard was placed in their mouth to avoid biting their tongue, and the administering physician would gently hold the mouth guard and the patient's chin during the procedure. Electrical currents were then administered for fractions of a second using a special machine, causing a general seizure that lasted 30 to 60 seconds. Patients would go unconscious during the treatment, leaving them no recollection of what happened, and doctors initially thought this was a good thing because it meant they had no negative thoughts or feelings about the experience. And that's very important because this whole ordeal could be very traumatizing to someone. After the seizures, doctors closely monitored the patient's breathing first and foremost. Now, this is where you may have seen restraints used with ECT. Patients who became anxious, combative, or had the potential to fall out of bed were usually tied down until they were calm and okay to answer simple questions. And you may think, well, someone who just underwent this procedure, strapping them to a bed may not be the best thing, and you absolutely might be right, but at the time, this is what was done. This new procedure was cheaper, more convenient, and far less risky than its predecessor, Metrazol. The seizure was triggered immediately, and the dose of electrical current was delivered with precision. Initially, ECT was slow to gain acceptance, and honestly, I can see why. Delivering electric currents to the brain was viewed as quite shocking. No pun intended. But at the time, beliefs about psychiatric care emphasized long, gradual paths to recovery. Think about institutionalization, whereas ECT challenged this view by demonstrating that patients could improve within a relatively short period of time. By the 1940s, the treatment had caught on in the United States, and by the 50s, it was widely used in state hospitals across the country, sometimes even as a form of anesthesia for the lobotomy. The process was further refined and improved by giving patients both muscle relaxers and general anesthesia beforehand. This helped calm them and prevented the most violent convulsions and injuries, making the whole experience far less traumatic. Now, I don't want to ignore the fact that yes, in some institutions, ECT was used as a form of punishment, especially for more disturbed or unruly patients. In 1942, ECT was brought to Central State Hospital in Milledgeville, Georgia, and it's documented to have been used as a form of punishment on some of the patients. But I don't want to give the impression that was every case, because for a lot of people, it was very helpful and yielded positive results. Understandably, there was a mix of medical, ethical, social, and personal personal opinions on the procedure. And it wasn't just doctors speaking out. Many people had family members in asylums who could potentially receive ECT. In 1985, the National Institutes of Health and the National Institute of Mental Health held a conference to discuss the concerns and questions about the procedure. Questions like which disorders should receive the treatment? What's the correct way to administer? And what are the potential risks and complications? The conference brought together a wide group of people from different backgrounds: neurologists, psychiatrists, legal experts, members of the public, and former ECT patients who shared their own experiences. Not surprisingly, reactions were mixed. Some patients had very positive feedback, while others still felt shame because of the stigma. Some of the findings from this conference may be surprising to you, and I think the most interesting thing is they found ECT is most effective for severe depression. In fact, it was reported that it yielded the same or better results than medication alone. Now think about that for a second, because that is huge. At this time in history, in the 1980s, state hospitals were starting to undergo deinstitutionalization, where asylums were closing and patients were being moved from state custody to community-based care. And with that, medications were relied on heavily because now people weren't going to be at a facility long-term receiving treatments and therapies. ECT offered another effective choice that could be done quickly and on an outpatient basis. It is noted that it works best when the patient is prescribed maintenance medication following the procedure, so they are working in tandem. They also found that ECT isn't very effective for people with schizophrenia, which was notable because it has been used for that disorder early on. The risks with the procedure are not as high as you would think. In a study, the mortality rate was 4.5 out of 100,000 patients. Really, the biggest risk here was complications from general anesthesia, which can happen to anyone, even undergoing a simple surgery. The rate for physical injuries like tooth damage, vertebrae compression fractures, or broken bones was almost eliminated, most likely due to the muscle relaxer and anesthesia given before the procedure. Side effects included headache, acute memory loss, or confusion. Severity of these depended on many things like how long the seizure was, how strong the electrical current was, how the electrodes were placed, and how often they were receiving the procedure. Doctors found placing the electrodes on both sides of the head rather than just one increased the risk for these side effects. ECT isn't some outdated, archaic treatment. In fact, it is still used today, mostly for people struggling with mood disorders like depression. It's not typically the first thing that doctors turn to, but it does become an option when therapy or medication isn't helping enough. And when that happens, ECT can offer a safe and effective alternative. Over the years, the procedure has continued to improve, and today doctors can use modern machines to deliver even more precise doses of electrical current, and a full team including anesthesiologists and nurses closely monitor the patient the entire time. With an effectiveness rate of about 80 to 95%, ECT is one of the most successful treatments in modern psychiatry, but because it's been portrayed so negatively in pop culture, many people still feel scared or even embarrassed at the idea of receiving it. Now, I simply cannot fit all of the information about ECT here in one episode, so if you are looking for any additional information, I highly recommend a book called Shock Therapy: A History of Electroconvulsive Treatment in Mental Illness by Edward Shorter and David Healy. I will link to that book in the show notes if you are interested in purchasing it. That's it for me today. Thanks for listening, and until next time.